Bismillahirrahmanirrahim. Today, while discussing the disorders of the stomach, today we are going to discuss a very important topic, and that is the peptic ulcer. In my previous lecture, I mentioned that acute gastritis, chronic gastritis, acute and chronic gastric ulceration, and even adenocarcinoma, all these disorders, they are interrelated disorders. Now, peptic ulcer, peptic means the stomach, while the ulcer means a sore or break in the mucosa. So, peptic ulcer affects the stomach, particularly the lesser curvature of the stomach, and also the duodenum, mostly the first part of the duodenum. If it affects the stomach, if it affects the gastric mucosa, it is known as the gastric ulcer. And when it affects the duodenum, it is then called as the duodenal ulcer. We all know that we divide the stomach mucosa into different portions. The portion of the stomach where the esophagus opens after entering through the diaphragmatic hiatus is known as the cardia. Then the body and fundus of the stomach and the antrum, which is the site of the stomach which opens through the pyloric sphincter into the first part of the duodenum. Now, the stomach mucosa contains different cells in different parts of the stomach. For example, the region of the cardia, it contains mostly foveolar cells, which are cells that secrete mucus, giving protection to the stomach against the hydrochloric acid, which is produced by the parietal cells located in the fundus and body of the stomach. Additionally, the fundus and body or corpus of the stomach also contain chief cells which are stimulated and they secrete a precursor form of a proteolytic enzyme known as the pepsin. So, pepsin is secreted as a precursor form known as pepsinogen, and the pepsinogen is converted into pepsin by breaking it down by the HCl produced by the parietal cells. The antrum of the stomach contains specialized cells known as the gastrin secreting or G cells. The same G cells are also present in the duodenum and the pancreas. The G cells, they secrete gastrin, and the gastrin then stimulates the parietal cells to promote excess secretion of the HCl, hydrochloric acid. Now we know that if the stomach mucosa is not protected by the protective mechanisms, the presence of the harsh acidic environment because of HCl, it would damage the gastric mucosa. And potentially, it may digest the gastric mucosa as well as the mucosa in the first part of the duodenum. The stomach is exposed to very harsh environment, and therefore its mucosa is comparatively thick as compared to the duodenum, which is momentarily exposed to the acidic contents that enter the duodenum through pyloric sphincter from the stomach. In the first part of the duodenum, the Brunner's glands are located, and these glands secrete mucus which is rich in bicarbonate, and this gives an additional protection to the duodenal mucosa and to the gastric mucosa. So the common sites for the peptic ulcers, in case of gastric ulcer, the common site is the lesser curvature and the portion of the stomach which is in close proximity to the pyloric sphincter. While in case of duodenum, the common site of the duodenal ulcer is the first part of the duodenum. Now going to the causes of peptic ulcer disease or causes of peptic ulcer, mostly peptic ulcer occurs in the background of chronic gastritis. And we have discussed that chronic gastritis is of two types: H. pylori gastritis and autoimmune gastritis. And here we talk about the H. pylori gastritis. Gastritis which is caused by the bacterium Helicobacter pylori. So it is one of the two most common causes of peptic ulcer disease. The second cause of peptic ulcer disease is the chronic use of non-steroidal anti-inflammatory drugs, which are very commonly used, and particularly patients of chronic painful disorders like rheumatoid arthritis, osteoarthritis, and other diseases. They use NSAIDs, non-steroidal anti-inflammatory drugs, for months and years. And here what happens, that these NSAIDs, they promote the peptic ulcer disease, and their mechanism of promoting the peptic ulcer disease is the inhibition of prostaglandin synthesis and their direct chemical effects on the gastric and duodenal mucosa. We discuss NSAIDs in a little detail in next slide. Corticosteroids also promote peptic ulcer disease, and they do so also by inhibition of the prostaglandin synthesis. A tumor which is known as gastrinoma and which is mostly present in the pancreas or the duodenum. Now this gastrin secreting tumor known as the gastrinoma is composed of the same cells as we discussed are present in the antrum of the stomach. And like the G cells in the stomach, these G cells present in the pancreas and in the duodenum also secrete excess gastrin. This condition is known as the Zoringer-Ellison syndrome, and it promotes the peptic ulcer. Cigarette smoking, which impairs mucosal blood flow and also interferes in the process of healing, can also be considered as a cause or a risk factor for the development of the peptic ulcer disease. Finally, the alcohol and psychological stress may increase the HCl production by the parietal cells of the stomach, and they may exacerbate the peptic ulcer disease. So, from discussing the causes of peptic ulcers, we come to the conclusion that excess production of ulcer is the fundamental problem that promotes the development of the peptic ulcer disease. And therefore, peptic ulcer disease mostly occurs in the background of the chronic gastritis, in which particularly the Helicobacter pylori and non-steroidal anti-inflammatory drugs, persistently irritate the gastric mucosa and cause excess secretion of the hydrochloric acid. Now coming to the Helicobacter pylori, what are Helicobacter pylori? The Helicobacter pylori are gram-negative bacilli. They are spiral shaped or curved shaped, and they have got some weapons to destroy the gastric mucosa. But here I want to mention one thing, that about half of the world population, if we examine, they have Helicobacter pylori in their stomach. And it may be considered as a normal bacterium or a commensal that lives in the stomach of the humans but do not cause damage to the person. However, at certain occasions, the Helicobacter pylori may cause damage to the stomach. Now, what is the pathogenesis behind the damage that is caused by the Helicobacter pylori to the stomach? That is, Helicobacter pylori are provided with certain weapons. First of all, they have flagella, and the H. pylori can use these flagella for moving in the viscous mucus that line the gastric mucosa. So, when a person is infected with H. pylori, and once H. pylori are in the stomach, they will face here a very harsh acidic environment. And to protect themselves from this harsh acidic environment, they will use their flagella and run to the sites where there is less acid. And the antrum of the stomach is a very favorite site for the H. pylori, because in this region, comparatively, there are little parietal cells, and as a result, the production of hydrochloric acid from the parietal cells is comparatively less in the region of the gastric antrum, and therefore this is a favorite site for H. pylori. Once in the antrum of the stomach, the H. pylori use the second weapon, and that is the expression of adhesion molecules. By using the adhesion molecules, the Helicobacter pylori adhere to the mucus secreting foveolar cells. So they have run from harsh acidic stomach into the area which is less acidic, and by adhesion molecules they stabilize themselves here. Now the Helicobacter pylori, for its protection, they have secrete an enzyme known as the urease, and this urease enzyme converts urea into ammonia, and ammonia is comparatively alkaline. So by converting urea into ammonia using the urease enzymes, the Helicobacter pylori around itself produce a comparative alkaline medium, and in this way it protects itself from the harsh acidic environment. Now once the H. pylori has stabilized by adhering to the foveolar mucus secreting cells, they will start secreting toxins, and these toxins produced by the Helicobacter pylori, they will damage the epithelial cells, the lining epithelial cells of the stomach and duodenum. And what happens, that when the epithelial layer is damaged, the cells here, they become dead. They will expose the underlying mucosa to the direct effect of the hydrochloric acid. Now here I want to mention that not each and every person infected with Helicobacter pylori will develop gastritis or peptic ulcer. Many people infected with Helicobacter pylori have no symptoms or problems. But the H. pylori has the potential to cause damage to the gastric mucosa and duodenal mucosa. And if this damage is of mild form, it may appear in the form of chronic gastritis, but if the damage becomes severe, it will cause erosion of the gastric and duodenal mucosa. And once they have eroded the gastric and duodenal mucosa, and when the superficial necrotic debris or necrotic surface is sloughed off, we see the formation of cracks or holes known as the peptic ulcers. In case of gastric mucosa, it will be gastric ulcer, and in case of duodenal mucosa, it will be duodenal ulcer. The second mechanism in which the non-steroidal anti-inflammatory drugs promote peptic ulcer disease is the chronic use of steroids and non-steroidal anti-inflammatory drugs. We know, and we have studied this in detail when we were discussing the inflammation, that the arachidonic acid, which is derived from the cell membrane phospholipids by the action of the enzyme known as the phospholipase, which is activated by the corticosteroids. Now, this arachidonic acid in inflammation is further broken down by either by the cyclooxygenase enzymes, which results in the formation of the prostaglandins, or by the lipooxygenase enzymes, which results in the formation of the lipoxins. Now here in the cyclooxygenase pathway, the enzyme cyclooxygenase, which is present in most cells of the body, they act on arachidonic acid and cause breakdown of the arachidonic acid into the prostaglandins. There are two cyclooxygenase enzymes known as the COX-1 and COX-2. Now, the prostaglandins, which are formed as a result of the cyclooxygenase enzymes on arachidonic acid, one of the prostaglandins very important is the prostacyclin PGI2. And this prostacyclin or prostaglandin is very important because it offers some protective mechanisms to the gastric mucosa. Now, what are these protective mechanisms? They will stimulate the mucus and bicarbonate ion secretion by the foveolar mucus secreting cells. The second effect is that the PGI2 or prostaglandin, it causes vasodilation and there is increased blood flow to the area. So this increased blood flow to the area in the stomach provide excess bicarbonate ions that neutralizes the acid, and moreover the acid that passes into the blood, it is rapidly washed away by the quick venous drainage. The third effect of the prostaglandin is that the prostaglandins and PGI2, it promotes epithelial cell growth. And the fourth and very important effect is that the prostaglandins, they inhibit the acid secretion. Now here we come to know that anything that inhibits the synthesis of prostaglandins deprives the stomach of very important protective mechanisms. Here, the corticosteroids, they inhibit phospholipase and inhibit the arachidonic acid metabolite pathway at the root. And therefore, steroids are involved in the pathogenesis of peptic ulcer disease. The COX-1 and COX-2 inhibitors, particularly the aspirin, brufen, indomethacin, and so many drugs that are available over the counter, they inhibit the enzyme cyclooxygenase. And by inhibiting the enzyme cyclooxygenase, they deprive the stomach of the very important protective mechanisms that are offered by the prostaglandins. So after H. pylori, the second most important cause of peptic ulcer disease are steroids, chronic use of steroids, and cyclooxygenase inhibitors or NSAIDs. These are the non-steroidal anti-inflammatory drugs. So the steroids as well as non-steroidal anti-inflammatory drugs, they are involved in the pathogenesis of the peptic ulcer disease. The third cause of the peptic ulcer disease is the Zoringer syndrome. As we discussed, that normally in the stomach, in the enteral portion or in the antrum of the stomach, there are specialized cells located at the base of the gastric pits. And these cells are known as the G cells. And these G cells, they secrete gastrin, which is carried in the blood to the parietal cells, which are mostly located in the fundus and body of the stomach, and the function of the parietal cell is to secrete hydrochloric acid as well as a very important intrinsic factor, which is important from the absorption of vitamin B12 in the ileum, and vitamin B12 is an important component of the red blood cells. Now here what happens, that like the G cells in the antrum of the stomach, as we mentioned, the G cells are also present in the pancreas and duodenum. Now if a tumor develops in these G cells, what will happen, that these tumor known as gastrinoma, it will secrete abnormally excess amount of gastrin, and the gastrin will stimulate the parietal cells of the gastric mucosa in the body and fundus, and will cause excessive hydrochloric acid production. And in this way, as hydrochloric acid production, excess hydrochloric acid production is fundamental to peptic ulcer disease. So here the gastrinoma, by inducing the Zoringer syndrome, promotes peptic ulcer disease. Now coming to the morphology, when we compare the ulcers in the stomach and duodenum, or the gastric or duodenal ulcers, we can say that duodenum is the most frequent site. Peptic ulcers are 4 times more common in the proximal duodenum than in the stomach. And here it is important to note that mostly the duodenal ulcers, they are located within the near region or within a few centimeters to the pyloric sphincter. And most commonly, these duodenal ulcers involve the anterior wall of the duodenum. Now, comparatively, the gastric ulcers, they more commonly occur where the body of the stomach and the antrum meets. at the interface of the stomach body or corpus and the antrum. Now, the base of the peptic ulcers is smooth because we know that the pepsin and the hydrochloric acid, it works as a dishwash by causing peptic digestion of the inflammatory exudate. And under the microscope, we can see different pictures in gastric and duodenal ulcers. In some situations, when there is an acute episode, we may see neutrophils or polymarconuclear leukocytes. Since this is a chronic condition, mostly in the form of chronic gastritis, we may see chronic inflammatory cells, lymphocytes, plasma cells, monocytes, and macrophages at the base. And even in very long-standing conditions, we may see a deep layer which is composed of fibrous tissue or scarring or scar tissue present. So we can say that the peptic ulcer is a very ideal picture in which acute inflammation, chronic inflammation, and excess granulation tissue formation can be seen at a single time. And the granulation tissue, which appears in increased region of vascularity, is the attempt of the tissue to replace the dead and necrotic tissue and to promote fibrous tissue formation and healing. In this picture, the one picture is the gross morphological picture in which the mucosal defect can be seen with clean edges. While in the second picture, the necrotic ulcer base, it is composed of granulation tissue, and we know that granulation tissue passes through two stages. Stage of vascularization, in which we see large number of blood vessels and fibroblasts, and then the stage of devascularization, in which we can see atrophic blood vessels and large number of the fibroblasts is in the process of fibrosis, healing, and repair. Now, what complications the peptic ulcers can cause? Number one, and the dangerous complication, is that the ulcers may be shallow or deep, single or sometimes multiple. But the deep ulcers are very dangerous because they can erode the gastric or duodenal wall, and if they come and if they erode a blood vessel, particularly if they erode an artery, this can result in extremely dangerous bleeding, and the patient will present as medical or surgical emergency. The second complication, in addition to the bleeding, is the perforation. And perforation will occur when the peptic ulcer erodes the whole length of the gastric or duodenal wall. This is particularly common in the duodenum. And this, we say that this is a transmural erosion which involves all the layers of the wall of the stomach or duodenum, mucosa, submucosa, muscularis mucosa, and the serosa. And here, once the peptic ulcer causes perforation in the stomach and duodenum, what will happen that the gastric contents or duodenal contents, along with air, they will enter the peritoneum. And this is also a type of serious emergency, medical or surgical emergency, because the contents and the airs, when they enter into the peritoneum through the perforation, they will stimulate the phrenic nerve which supplies the diaphragm, and this irritation of the phrenic nerve in gastric ulcer perforation will give rise to the referred shoulder pain, which is a very important sign and symptom in case if the ulcer has perforated. Sometimes and very rarely, if the acute severe complications doesn't occur, repeated attacks of inflammation and healing, particularly in the pyloric sphincter, will cause so much edema formation, exudate formations, and so much scar tissue formation in the pyloric sphincter that it will give rise to the gastric outlet obstruction. And the patient will present with severe vomiting, nausea, and abdominal pain. The symptoms of the peptic ulcer includes epigastric pain, described by the patient as an aching or burning in the uh, epigastric region. The patient may suffer from bloating, bleaching, and sometimes vomiting. And here, very important thing that I want to mention, that the gastric ulcer, a patient with gastric ulcer, when eats food, the physical presence of the food in the stomach stimulates the hydrochloric acid secretion and the patient cries of pain. So in gastric ulcer, pain is more severe as soon as the patient takes the food. While in the duodenal ulcer, the patient who was feeling pain, but when he takes the food, the pain is relieved. And therefore, clinically, the gastric and duodenal ulcers are divided by the characteristic that pain in gastric ulcer becomes severe after eating the food, while the pain in duodenal ulcer, it decreases when the patient eats the food. And this is the reason that patients of gastric ulcer, they lose weight because they try to avoid eating. While those with duodenal ulcers, they gain weight because when they eat, their symptoms and pain is relieved. Diagnosis of peptic ulcer, as I mentioned, that peptic ulcer disease generally develops on a background of Helicobacter pylori induced chronic gastritis. In our previous lecture, we have discussed chronic gastritis as the one H. pylori gastritis and the other autoimmune gastritis. Here we are talking about the Helicobacter pylori induced chronic gastritis and peptic ulcer. And as I mentioned, that the same peptic ulcer can also be caused by non-steroidal anti-inflammatory drugs. So when we examine a patient of peptic ulcer, we must do some things, the initial investigation to exclude the presence of Helicobacter pylori and to test the patient for the presence of chronic gastritis, which is commonly caused by the Helicobacter pylori. So for Helicobacter pylori induced chronic gastritis, we can use the fecal matter of the patient for the bacterial antigen. We can also use some serological tests in which antibodies to H. pylori are detected, and other tests, for example, urea breath test and other tests can be done. But particularly for peptic ulcer disease, we will use upper endoscopy. We will introduce endoscope through oral cavity, esophagus, stomach up to the duodenum. And by using the endoscopy, we can directly visualize the ulcer. And during endoscopy, we take a biopsy from the lesion and we have to examine this biopsy specimen. We have to culture it for H. pylori, and also we may make a histopathological examination to exclude the presence of malignancy and to assure the H. pylori, presence of H. pylori. Because I have mentioned that both the types of chronic gastritis, H. pylori gastritis, autoimmune gastritis, they are strong risk factors for the development of the adenocarcinoma in the stomach. The treatment of pyloric peptic ulcer disease depends on the presence of the underlying cause. If the underlying cause is removed, the disease is treated very well. And this should be done before the peptic ulcer disease progress so much to cause serious complications. And fortunately, various combinations of antibiotics and acid lowering drugs, particularly the proton pump inhibitors, they are available with short courses, and we can use the H. pylori gastritis and peptic ulcer disease by these medicines. Moreover, we must look for certain substances that may facilitate or promote peptic ulcer disease. For example, if a patient is chronically using non-steroidal anti-inflammatory drugs, if a patient is chronically using steroids, and if the patient is using the alcohol, tobacco, or caffeine, we must strictly advise the patient to stop these medications. Sometimes when the treatment fails, which may occur in more advanced diseases and in diseases that carries high risks of complications, or if an actual complication occur, then we will make surgery to treat the disease. Now, this is a summary of the peptic ulcer disease. Peptic ulcer is a sore or break in the mucosa. It may be in the form of gastric ulcer or duodenal ulcer, and the major underlying cause is gastric hyperacidity, excess production of hydrochloric acid from the parietal cells of the stomach, and the causes includes the Helicobacter pylori infection, using steroids and non-steroidal anti-inflammatory drugs, the gastrin secreting gastrinoma and Zoringer-Ellison syndrome, and the common sites are the gastric antrum and first portion of the duodenum. Sometimes, if an ectopic gastric mucosa is present in the esophagus, for example, in conditions of Barrett esophagus, or if there is heterophagia when gastric mucosa is present in small intestine, in conditions like Meckel's diverticulum, ulcers can also develop at those sites because of the presence of the gastric mucosa. Morphologically, the ulcers are round or oval, punched out holes with raised margins. They may be solitary, or there may be more than one source. The ulcers may be shallow or deep, which are more dangerous. And histologically, the base of the ulcer is clean and soft due to the dishwash effect of the hydrochloric acid and gastric enzymes, which cause peptic digestion of the exudate. And under the microscope, we can see the rich vascular granulation tissue. And sometimes, if we go further deep, we may see chronic inflammatory cells and scar tissue, and fibroblasts. The complications are bleeding, perforation, and pyloric outlet obstruction. Diagnosis is made mainly by the endoscopy and biopsy, and the treatment of the peptic ulcer is to remove the cause and to treat the symptoms. Thank you very much.